This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Well, welcome to our podcast on the cardiac CT from prognosis to diagnosis. And with me today, I have Dr. Satinder Singh, who's professor of radiology and medicine in the Division of Cardiovascular Disease. He's actually chief of the Cardiopulmonary Radiology and director of the cardiac CT at the University of Alabama in Birmingham. So, Dr. Singh, welcome to MyHeart.net podcast.
Thank you, Dr. Bouchard.
Thank you for taking the time to do this with us. We know that non-invasive cardiac imaging has evolved significantly over the last several decades. Advances in technology and the development of newer CT system with improved spatial and temporal resolution, shorter imaging time with less radiation, and with ECG gating allows for the imaging of the beating heart. Cardiac CT is the fastest growing imaging modality in the field of cardiovascular disease. From diagnosis to prognosis, and how cardiac CT with calcium score and CT angiography can help us taking care of our patients. And this is primarily what we're going to discuss today. Recently, the cardiac CT calcium score was integrated in the new guidelines for primary prevention of cardiovascular disease in asymptomatic patients with mild to moderate risk of atherosclerotic cardiovascular disease. So, Dr. Singh, if you could tell us a little bit more about this. What is exactly the calcium score? How is it calculated? How do we actually, how is it done? How do we obtain, those images with our patient?
Yes, sure. So the calcium score is done with a CAT scan or computed tomography, which is commonly used for several CTs of the head, body, chest, etc. It's the same machine. We do not give any intravenous contrast. Most of the studies are usually EKG gated so that we can reduce the motion-related artifacts. But there are newer techniques now where we can use, especially with the dual source scanner, a very high pitch protocol. That means the table moves so fast that we can just image without gating the study also. There is no special preparation for the patient is required. They just make an appointment and show up at the time. Once the patient is on the table, the technologist will hook up the EKG leads and give them instructions to hold a one breath hold during the scanning. And it only takes one breath hold to scan the entire heart, which is usually less than 6 seconds or so. The total CT room time is maybe 5 to 10 minutes from start to finish, but actual image acquisition is less than 6 seconds. And then after those images are then sent to a special software, and actually many vendors have these software now, which then determine the presence of calcification based on a CT threshold value of 130 Hounsfield units. Anything above that value is considered calcification. And one need to be very careful that if the stent is present, one should not include the stent in that calcification score. And then from there, you get the Agatston score, its volume and density features. The results are usually available within an hour or so, at least at our facility. And depending upon the insurer, some third-party payer do pay for this. Otherwise, people might have to pay on their own. And the cost is is very minimal, around $100 or so, usually.
But what does the calcium score tell us, Dr. Singh?
Yes. So the calcium score, basically, it represents presence of coronary atherosclerosis. It is a highly specific feature. If you see calcium in the coronary artery, that means the patient has coronary atherosclerosis. And there is a very consistent and reproducible evidence seen from multiple studies that there is a strong association between the coronary artery calcium score and major cardiovascular outcomes, especially in asymptomatic individuals. It has been shown to have added value to the conventional clinical risk assessments, such as Framingham risk scoring, which we use in this country, using age, sex, hypertension, presence of diabetes, hyperlipidemia, and smoking. And therefore, it can serve as a guide, especially for initiating or deferring preventative therapies, especially statin use in a particular patient. There is some data also that presence of coronary artery calcification may be associated with higher risk for heart failure as well as atrial fibrillation. But main use is for adding to the clinical risk assessment and changing the category of the patient based on presence or absence of calcification.
So we have this patient, maybe between 40 and 75 years old, and they do have some risk factors, whether they smoke, they have a high cholesterol, and their blood pressure is elevated. And we want to get a calcium score, and we get different categories. Can you explain to us a little bit these different categories, and what does it mean in terms of, what does it tell us in terms of prognosis over the next 10 years?
Right. So if the calcium score is 0, that usually means that there is no identifiable atherosclerotic calcified plaque in the coronary artery. And that has been shown to have a very low cardiovascular disease risk in the next 10 years. The score between 1 to 10 is referred to as a minimal plaque and is associated with low cardiovascular risk scoring. Between 11 to 100, it is a mild plaque with moderate cardiovascular disease risk, and score between 101 to 400 is a moderate plaque burden, and it is associated with higher cardiovascular disease risk. And any score beyond 400 usually means the patient has extensive atherosclerotic plaque and has a very high cardiovascular disease risk in the next 10 years or so.
So there was a recent article just in March, actually, in circulation on calcium score greater than 1,000. Can you tell us a bit about that?
Yeah, greater than 1,000. In my practice, usually people who have a very high coronary artery calcium score, they are usually not a good candidate for evaluation with coronary CTA because of the artifacts which are derived from the coronary artery calcification. However, having said that, we have seen several patients. Actually, there were 2 patients last week who had a score of 1,600 and one had a 2,400. And we did a coronary CT calcification because the patient had indeterminate stress tests, and we went ahead and did it. And in these cases, it's very, very important that you try to minimize any other artifact which can be generated, especially cardiac motion artifacts. So you really want to decrease their heart rate. You want to give them nitroglycerin so you can dilate the coronary artery properly so you can see the lumen well. And breathing instructions, I think this is one thing which people don't realize. If you breathe during this scan, nothing can be done. That study is ruined. It's just like a garbage in and garbage out. So if your study is not good, you cannot give any good data out of it. So in these 2 cases which we did, we were able to see the coronary artery. The cases where the coronary artery calcifications were very dense, even those areas we could see the lumen and approve, and there was approximately 40% luminal narrowing. But we could see rest of all 17 segments of the coronary artery quite well. So both of these patients don't have obstructive coronary artery disease based on CCTA, despite very high calcification. So it is only our own experience. Of course, if the patient is very big, 350 pounds, and heart rate is high, and then there is no point in doing this score. This will be useless study.
Very good. So I think in the Johns Hopkins experience, it seems like the when patients have terrible, very high calcium score, it seems to be, correlating with the presence of subclinical disease. It means, here we already have some buildup of plaque, and it seemed to have some kind of impact on their long-term survival, not only from the point of view of the cardiovascular standpoint, but even from the point of view of having more cancer, more dementia, seems to really being affecting the patients, a lot more. But I think the jury obviously is still out, and it seems like it's good that you were able to perform a coronary angiogram using the CT, even with that amount of calcium. I guess calcium being that high, it's not only in the coronary arteries, but it's also on the valve, isn't it? And in the aorta to get that high score.
Yes. Patients do have atherosclerotic disease in the aorta and its branches. Yes, true.
Well, if we have a calcium of 0, usually it's related, to a very good prognosis. And with the MESA study they were quoting, cardiac coronary event of less than 1%, over a period of 10 years. But what is the warranty of calcium score of 0? Is this actually something that we should feel good and never measure again? Or is there a point of measuring later on in the future?
Right. So many studies have shown if the coronary artery calcification is 0, the overall, at least short to intermediate long-term prognosis is good in terms of having cardiovascular events. However, the coronary artery calcification can progress over time, especially if the patient has any underlying risk factors, especially uncontrolled high blood pressure, hyperlipidemia, or diabetes. So these patients especially needs to have a repeat coronary calcification. Now the jury is out. What is the time period for doing repeat calcification? It is nothing like mammogram yearly or lung cancer screening yearly. It needs to be done maybe 5 to 10 years. Some people say 10 years is at least required. But there are studies which have shown in 5 years, if you have a 00 at baseline and 5 year, that is a stronger predictor that you will not have event in the near future. So certain group of people do need to have a repeat calcification. And this is what was used in the cardiac study, which is going on for the last 30 years. And they have done a 10-year interval scans of these patients.
Very interesting. So we have some patients, of course, that we want to prevent coronary disease. They have high cholesterol, and we start them on the statin. And what we're trying to find, a statin that doesn't, that they seem to be tolerating very well. We have some patients that are very sensitive. They have muscle pain or arthralgias, and we go through a different rounds of different statin, and they're still having problem tolerating it. How about doing a calcium score? I mean, is it still valid? I mean, it seems like, statin do change a little bit the way the plaque modulates in the coronary arteries. What is the experience of doing calcium score in patients that have taken statin?
Right. So statin, the trial where the cholesterol management guideline initially used coronary artery calcification score in guiding the decision to initiate statins in intermediate risk category. But at that time, they also said that there is no clinical utility of coronary artery calcification in statin user. This was based on one study by Lee, which showed that although the percent atheroma volume progressed slower in statin user, the progression of calcified percent atheroma volume increased more rapidly. Reinforcing the data that statin may actually increase the coronary artery calcification progression. Now, having said that, we know that statin do stabilize a vulnerable plaque, making them more fibrous and ultimately more calcified. And over time, because of that increasing calcification, the Agatston calcium score will increase. So this is a paradoxical effect, because you're saying, if coronary artery calcification is 1 today and after, 4 years, it become 10 or 50, it's worsening. But actually, this is expected because of the statin effect on the plaque. Now, there was a recent study which was published recently this year from a very large coronary artery calcification consortium, and they used that data retrospectively, and it was information based on baseline statin use with a mean follow-up of 11 years. And in this study, they looked at different components of coronary artery calcification, the volume, the area, and density differently, not just one single score. So what they found is that in statin users, both Agatston score overall and coronary artery calcification volume still had prognostic utility for coronary heart disease and cardiovascular disease risk. But also they also found that because of this increased calcification, there was a paradoxical shift, or it was not completely agreeable that you can say that the prognostic significance of coronary artery calcification is 100% useful in statin user based on just density, because we know the density will increase. So I think it is interesting. This is an interesting area which needs to be explored further.
It really seems like the calcium tends to form in the proximal portion of the coronary arteries, and the statin may be in preventing further development or worsening of atherosclerosis, maybe preventing plaque and calcium buildup in the mid to distal portion, which is kind of the natural progression that we see normally. So it looks like there's still some useful information getting a calcium score in a patient that are statin intolerant when they have a very high score, indicating that it could be some benefit to really pursuing cholesterol treatment, in these patients, maybe even not a statin, but other forms of therapy like, the PCSK9 inhibitors, or maybe ezetimibe. How about calcium score in the young? I mean, obviously the MESA study concentrated its effort on the 40 to 75 years old. What experience do we have in patients that are in their 20s and 30s? Is there some value in doing calcium score, I guess, in patients that we're concerned where they have a lot of risk factors?
Right. Actually, there are a few studies which have shown that the coronary artery calcification can be useful in younger patients, younger than 45 years. And this is a recent study which was published by Jeff Carr at Vanderbilt. It was in JAMA from the Cardia study. So the Cardia study is a prospective community-based study, recruited almost 5,000 participants. And these patients are under surveillance for 30 years. And their coronary artery calcification is being measured, I think it was measured at 15, 20, and 25 years after recruitment. So what they found is at 15 years, 10% or so patients had coronary artery calcification. And those patients with any calcification had 5-fold increase in the coronary heart disease event. And also, if the coronary artery calcification is more than 100, they had association with early deaths, almost 22% increased early deaths. So what they concluded that, in patients, especially between 32 to 46 years, there is increased risk of fatal as well as non-fatal coronary artery disease on follow-up, as well as in adult younger than 50 with any calcification, even with a low score like 1 to 0, or 1 or 1 to 10 or up to 100, there is elevated risk of clinical coronary heart disease and cardiovascular disease as well as death. So they speculated that selective screening for coronary artery calcification might be useful in selective individuals who have risk factors especially with early adulthood, with the family history or some other risk factors, they can be really benefit from coronary artery calcification scoring.
So that's very interesting, and I guess we're going to see a lot more, research in that area, because if we want to prevent coronary disease and coronary event, we have to start in a young age, and certainly, in that patient group of 20 and the 30s, it seems to me that this is where it's time maybe to take some action, particularly in patients that are at high risk, and maybe the ones showing already evidence of calcium. So let's say, for example, so these are patients that are asymptomatic. We want to prevent coronary disease, but we see sometimes patients that, that have atypical symptoms. I mean, the pain is really kind of not classic. They do have some risk factors. What kind of experience do we have getting a cardiac CT, particularly a calcium score? How does it compare, for example, to stress imaging that we do in the office, or do we have any data actually on the calcium score in relation to patients undergoing angiogram in that group of patients that have atypical chest pain?
Right. So currently there are no guidelines which endorse use of coronary artery calcification in symptomatic patients, including those who are at low risk for coronary artery disease. But having said that, there is some data out there, which is, I think, slowly growing, and probably it will further change these guidelines in future. As we know, choosing the image modality in a patient with chest pain, it all depends on the pre-test probability. If the chest pain occurred in a patient with very high pre-test probability, you don't want to do any other imaging but to take him to the cath lab and do some intervention if required. But in those patients where pre-test probability is not very high and they have atypical chest pain and their troponin is not elevated and EKG is non-specific, not typical for ischemia, in those cases, currently, I think the first test which we do at UAB, especially patients who are presented to ED, is often coronary CTA with contrast. But presence of coronary artery calcification instead of CCTA is an interesting thought. I mean, because we know if the calcium score is 0, the outcome is usually good. At least you can have that, and then you can follow these patients, and down the road you can do some imaging. Having said that, it becomes somewhat, I think, situation become uncomfortable, especially in the ED setting. If the patient is having chest pain and you just do a calcium score and tell them you don't have a calcium score, you go ahead, go home. Because there are some group of patients where you may not have calcification, but they still may have a non-calcified plaque, which might be causing the coronary artery obstruction and symptomatic. So you might miss those patients if you just look at the calcification. So for that reason alone, I think, and of course, that's a big medical legal issue also. And that is the reason we do a lot of testing and unfortunately a lot more what we need to do. But there is some role. I think it may not be in the ED setting, but it may be in the clinic setting where the patients are kind of stable. They are symptomatic, which we do not know. And those patients can be scanned with calcium score and down the road, maybe scanned with something else. I don't think there is any large randomized data on a study on this topic. There is some kind of discrepancy between calcium score and myocardial perfusion imaging as well. There are a few studies which have shown patients who have a 0 calcium, they often have positive myocardial perfusion study. This is not a very large number, but their outcome is based on 0 score is not significant. So despite, I think, the ischemia being positive, calcium score, I think, does have a role, but I think we need more studies to compare between the calcium versus myocardial ischemia. There was one study also which showed that in patients who have a zero coronary artery calcification, there was approximately 12% or so who had abnormal stress myocardial perfusion study, with the majority showing a small perfusion defect, which is usually less than 10% of the LV myocardium, and only 4% showing a large defect, more than 20% of the LV myocardium. But irrespective of this normal or abnormal, their annualized event rate was still low because their calcium score was zero. So I think this needs to be further evaluated because there is some discrepancy between these imaging tests.
Yeah, I agree. And there's also the situation where, in these patients where you do a myocardial perfusion imaging because of atypical chest pain, low risk patient, you have a normal stress test, which usually is associated with very, very, with good prognosis and very small cardiac event over the next 2 to 3 years, let's say. But, obviously a lot of these patients can still have a lot of calcium buildup and have an elevated calcium score as compared to if you have, a normal calcium score of zero. That does actually bring you a very, very good prognosis over maybe a more prolonged period of time, maybe 5, as you said previously, 5 to 10 years. It seems like among the patients that have a normal stress test, you can have some patients with elevated calcium score, which may be, pointing toward more cardiac event, and therefore maybe not as long of a warranty possibly. Anyway, some kind of interesting studies that probably will sprout over the next several years. What about the calcium that is evaluated? Let's say we have a patient coming in the emergency room for atypical chest pain, and we want to rule out aortic dissection, and we want to rule out a PTE. We'll do a CT that is non-cardiac gated, and then we see some calcium. Actually, is there some? Are you doing this at UAB where you're reporting the amount of calcium, in those patients? And because it seems like it has some good relationship with the actual calcium score and maybe even the prognosis in these patients.
Yes, actually, we do report it. And specifically for the lung cancer screening studies, we reported there's a visual coronary artery calcification score on non-gated routine chest CT or low dose lung cancer screening CTs, which we have validated with the Augustin score. This is also known as Weston score, visual assessment. And based on it, we give them different numbers. 0 is no visual detected calcium. 1 is only one single high density pixel without any blooming artifact. 3 is very high calcification with blooming artifact, and 2 is in between these two. It's somewhat subjective, but we did a study and the variability was not significant. So because there's a range, so we can predict that if this number turn out to be visual score is more than 7, it is a significant calcification, which correspond to more than 400. So yes. Now, having said that, the problem is we report on all lung cancer screening CTs, but I'm not sure whether anybody act upon that. I mean, I think there are few studies out there. We have not looked at our data. There's a data from UCSF where they say, we report it and they act upon it if needed. But I'm not sure if it is true in our population here. Now, for the other ED scans for PE or aortic dissection, if we see calcification, we do report it. We do not give the Western score because those scans are often done after hours, and those folks, radiologists who are reading it, they are not dedicated chest and they do not know this visual scoring. But we encourage them to at least, report it, that presence or absence of calcification, especially if you see in a younger patient, which is much more important.
Very good. So that's our first segment on the calcium score. I think it's a study that is very quick. It's usually gated to the electrocardiogram. Takes about maybe 10 to 15 minutes and provides a lot of information and really helps us reclassify the risk of a patient that is asymptomatic and has not had any evidence of coronary artery disease. It helps us evaluate the plaque burden and helps us also evaluate how aggressive we need to be with the treatment of their cholesterol, as well as treatment of their blood pressure, whether they would benefit from aspirin. It's also helpful in patients that have taken statin, try to evaluate these patients. And we've discussed that, the different spectrum of calcium and zero, giving us a very good prognosis over a period of 5 to 10 years. It probably needs to be reevaluated. And calcium score that were greater than 400 and calcium score that were greater than 1,000, indicating the presence of subclinical disease, where we need to be very aggressive treating these patients almost as if they have, coronary artery disease, and giving them the medication that we give for secondary prevention. So let's talk now about the second portion, and that is the CT angiography. We know that CT angiography has undergone significant development, and with multiple clinical studies demonstrating its accuracy and its potential to guide clinical decision-making and improve prognosis also compared to the standard stress imaging protocols. So tell us a little bit about, CT angiography. This is done primarily in patients that have symptoms of chest pain, but that usually low to intermediate risk, as we mentioned previously. Well, let's talk about the technological requirement. Let's talk about, can we do that on any CT? What is required to get a good CT angiogram, Dr. Singh?
Okay. So first of all, in these cases, a patient preparation is crucial. Once we decide that we are going to do coronary CTA, we need to figure out first whether these patients have any kind of contrast allergy or they have any renal insufficiency, because we do need to give intravenous contrast. And also we need to note that if they have any kind of pacemaker, for which we may need to modify the protocol or use slightly different filters. And also, it's important to know if the patient has prior bypass surgery, because if they have it and we do want to evaluate those bypass scan, we might to extend the field of view of the scan above the clavicle all the way to the diaphragm, rather than just concentrating on the heart. That's number one. So once we decide that, okay, patient is ready to come, these patients preferably should take beta blockers. We advise at least 2 to 3 days before. It's not just to decrease the heart rate, but also what we found, even with patients who have a lower baseline heart rate, if you give beta blocker, the variability which can occur during image acquisition is lower. So that is quite important. That's important for getting a good scan. And once the patient is here, we explain to what to expect it. And they are also advised not to have a solid food for 4 hours, no coffee or stimulant. And if they're using any kind of erectile dysfunction medication, they need to stop that for 24 hours and do not take after 48 hours. And we tell them to come at least 30 to 60 minutes before, because patients are usually anxious. That will increase their heart rate. Once they come down and settle down, you talk to them, they become, more rested and heart rate goes down. Then nurse will start an IV access. The IV usually is in the antecubital fossa. We definitely need at least 20 gauge, because the contrast rate of injection is anywhere between 4 to 5 cc, because we need a good solid bolus. So you need at least 20 gauge or 18 gauge access. And we test that with test flush with saline in case, it is about to blow out. And once the patient is on the table, we put electrodes for EKG and connect it to the machine. And we check the heart rate and check with variation with any breathing. We tell them take a breath in and blow out and see if there is any variation in the heart rate. And if there is, then we might give them additional intravenous beta blocker in 5 milligram increment up to 15 milligram metoprolol, slowly injected, check their blood pressure, and watch for the irregularity of the heart rate. And then also definitely practice breath hold. It's very, very important. I think this is the thing which many people forget. That is very critical in these coronary CT angiograms. So once the patients are ready, we inject the contrast, usually between 4 to 5 cc's. Technique of scanning is different based on the indications. Now, before I go in, any scanner which is 64 detector or more can do coronary CTA. I mean, when we started doing coronary CTA, we did it on 4 detector and 16 detector. But to get a good quality scan, it has to be at least 64. Most of the majority of the machines which are now available in the market often have, 126 or 320 or more than 320 detectors. And we also have a dual source scanner as well, where there are 2 X-ray tubes which can go very faster. And these are the machines where we can do what is called a high pitch scanning, where the table can move very fast and you can scan the study in very short interval. There are different CT protocols, so we have to choose what is best for a patient. If the patient's heart rate is good and stable, and we are looking only at the coronary arteries, we can use a prospective EKG triggering. That means the machine is only on for a short period of RR interval, the EKG interval. And it is called a step and shoot mode because machine is on for one time, then the table moves, and then again machine is on. So it is a step and shoot kind of mode. The biggest advantage of this is the radiation exposure is very minimal because the X-ray exposure is only limited for a very small period of time. The disadvantage is if patient take a breath or if there is arrhythmia, the study can be ruined because you do not have multiple phases. You have only one phase which is available. The other thing is you do not have any functional data with these kind of scans. So if you are looking for functional data, which sometimes we do, especially for patients who are being evaluated for congenital heart disease, we do a retrospective gating where the X-ray is on throughout the RR phase. In those cases, the radiation is slightly higher, but you get all the functional data. And by chance, if one phase is degraded from whatever reason, you have other phases to work on. So that is the biggest advantage of retrospective over prospective gating. We have used high-pitch protocol. We use high-pitch protocol very frequently for aortic dissections if they are in the outpatient setting, for PEs, because it reduces the radiation exposure up to 40%. I mean, that's phenomenal. And the studies are very good. In fact, many of these studies, because the scan is so quick, it almost produces images like patients have taken beta blockers. So you can even see coronary arteries quite well.
What is the radiation that is, the radiation has decreased significantly over the years, radiation exposure. If you could compare that, for example, to other techniques that we use in cardiology, like myocardial perfusion imaging or even a chest X-ray,
Right.
Or even a cardiac catheterization, what are we talking about?
Okay, so for coronary artery calcification score, it is less than 1 millisievert, usually around 0.4 millisievert or so, or even less. It all depends on the patient body habitus too. If the patient is very large, it may be slightly more, but not a whole lot for calcium score. For coronary CTA, again, it depends on patient body habitus and what kind of study you are doing. And if you end up doing retrospective, now I would say between 1 to 5 millisievert total retrospective cardiac CTA. We have seen, we have done studies with retrospective gating in a small patient, 160 pound, with only 2 millisievert. I mean, beautiful study, entire cardiac function. The catheter angiography, again, depends, how many views you take, how much contrast, how much fluoro, how heavy is your foot. Ideally, I think it is between 3 to 7 millisieverts. Many conscious people are, even less, they know, they take very few images. A chest X-ray is almost like 0.02 to 0.04 millisievert if you're taking one view or two views. A regular chest CT without contrast or CTA is anywhere between 5 to 7 millisieverts. Maybe stress is again variable. They used to be very high dose. I think they have decreased now too. They are anywhere between 5 to, I would say, close to 20 or so millisievert if you do both rest and stress. And also, interestingly, any transatlantic flight, you get exposed. There is a 3 millisievert exposure.
Amazing.
And a yearly background is also between 3 to 4. I mean, Philip just went to Montana. I think he got exposed to 4 millisievert probably.
Actually, it shows in his face.
Yeah.
It was radiation. Well, particularly the system, maybe the myocardial perfusion imaging, when you use the thallium, the dual isotope, really the radiation really gets, in the 20 to 23 millisievert. Therefore, the advantage of using, other protocols, more primarily with technetium, where you can reduce patient exposure to radiation. But, it's amazing to me that the CT angiography, with the new, development and fast techniques, thin slice, multi-detectors, multiple sources. I mean, you get radiation exposure that are really minimal. It's really fantastic.
Correct.
What about for the patient, standpoint? I mean, I guess the size matters. You did mention, obviously that if you have patients with larger BMI, is it still a problem? You get really not very good imaging as well as more exposure if you have BMIs of 35 to 40, and you still do them sometimes, or?
Well, we have done that because those are the problem patient for everyone, right? I mean, you really, physical examination is limited. You cannot do echo very good. Catheterization is kind of difficult too. So CT turned out to be, a good modality actually. We have done quite a few, even reaching up to 500 pounds. There was one patient we did for 500 pounds. Of course, the radiation dose is phenomenal. You have to increase the exposure, but there was no other way to look at inside the patient. And so in these cases, what we try to do is, try to decrease other artifacts, control the other things which can produce artifacts, heart rate, breathing artifacts, sometimes giving them oxygen on the table helps them. If their patient is anxious, that helps them. We have to give them more contrast because their blood volume is so much, usual 40 to 60 ml is not enough. They might need even 100 cc, but much higher rate, more than 5 cc per second. So I think there are, I would say there are situations where you still don't get good study. It all depends on the machines too. Some machines cannot generate enough photons, juice, but the dual source, if you have two different X-rays, they have two generators, so they can really pump up. So we have to be very careful. We have a limit applied with how much they can go up. Otherwise, they can go blast them, with the 80 millisieverts in one scan. Wow. So it is always difficult. If you have a good machine and if the patient can tolerate high rate of contrast injection, breath hold, we can get a decent study. I won't say it's the best study, but decent study.
So regular heart rate, BMI, preferentially less than 40, normal renal function, you have to hold your breath, tolerate beta blockers. You lift both arms above their head? Or
Yes, usually both arms above their head, because if the arms are beside, they produce a lot of artifacts.
Right.
But if the patient cannot bring arm above, we try to put a pillow on the chest and tell them to kind of hug the pillow, so it can go get away from the field of view of the carina and below.
Do you use also nitroglycerin? Is that why
Yes.
You're concerned with
Yes, we prefer if we can give nitroglycerin if the patient has good blood pressure and there's no other contraindication. Of course, patient, with aortic stenosis, we do not give them.
Right. So obviously the CT angiogram has performed very well. Could you tell us a little bit about maybe some of the comparison? How does it compare to a coronary arteriogram? And how does it compare also to functional stress imaging in terms of sensitivity and specificity?
Right. So when we look at the sensitivity and specificity between different modalities, so there is data comparing exercise treadmill, exercise echo, dobutamine echo, nuclear treadmill, adenosine treadmill, and coronary CTA. Coronary CTA sensitivity specificity is the highest. It is upper 90s and close to upper 80s and 90 respectively, sensitivity and specificity. Nuclear scan is close to 90, the sensitivity, the specificity is in the 70s range. Echo is slightly, it's in the same range actually, echo also, dobutamine as well as exercise echo, treadmill test. So CT has a pretty high sensitivity and specificity. But provided, you really need to get a good imaging with all the factors we just discussed. So, if you have a good study, it will be very easy to interpret and diagnose any kind of disease.
So that means that for CT angiography, we have a very high sensitivity in the order of 97% with very good negative predictive value. That means if a coronary CT angiogram is normal, there's very high likelihood that patient is going to do well.
Right.
But it may be a bit more difficult when you do have coronary lesion or coronary calcification. How does it compare to the angiogram in that respect? I mean, is that a pretty fair comparison?
Now, when there is calcification, I think calcification is still our enemy. I mean, we have not solved that issue, even despite all this technological advancement. I mean, if there is dense calcification, CT tend to overestimate stenosis. We have seen that. We call it and patient taken to cath lab. There is not significant stenosis. It's mainly because of the blooming artifacts. I mean, calcium give rise to blooming artifact, and you cannot really see the lumen. Now, having said that, with the newer scans, I think the quality has improved. The blooming artifacts have decreased. And if you are doing a dual energy scan, there is a study which has done a dual energy scan, which range from 50 kV to 140 kV. In the 140 kV range, the blooming artifact, the calcium goes down very significantly. So, but those are only anecdotal studies, but calcium remains our enemy. I think you have to be very cautious when you are reading patients' CTAs with very heavy calcification. We always put a disclaimer that, this may not be accurate, what we are telling. I tend to lower my numbers. If I'm suspecting 50%, I'll say usually around 30 to 40%. It's not significant because this is what I have seen in my experience. You tend to overestimate.
There is something that is very, very characteristic of the CT, because you're taking a tomographic image in the body. Not only you see a reconstructed angiogram, but you're able to see actually the plaque morphology, probably even better so than the coronary angiogram per se. Can you tell us a little bit about this? I mean, does plaque morphology matters?
Absolutely. So if you compare coronary CTA and invasive catheter angiography, Both show the lumen, but what the best part of the CTA is it shows the wall of the coronary artery where the plaque is. So you can determine if the patient has a plaque and what kind of plaque it is, what is the extent of the plaque, how many vessels are involved. And also you can characterize the plaque. There are certain features which can tell us that the plaque is more vulnerable as compared to non-vulnerable plaque. And those are, number one, the positive remodeling when the vessel in the initial stages where the plaque is usually not calcified, but it is building outward. In these cases, the lumen is not narrowed. So CT angiography will show the plaque, but catheter will not. Catheter angiography will be total normal. Number one is the positive remodeling and the low density of the plaque, because vulnerable plaques are those which are lipid rich. Now, jury is still out on that. You can see the low density, but it is very, very heterogeneous. As we know, this plaque building is a systemic chronic process. So it is not one step. So most of the plaques are heterogeneous. So it depends where you put your cursor to determine the density. So what we decide now is whether it is a calcified plaque or a non-calcified plaque. Everything from fibrous to lipid is lumped together in non-calcified. So positive remodeling, low density, spotty calcifications, if you see them, those are features. This is similar to IVUS, what we see. And of course, if the plaque volume is large, that is also a high-risk feature, which we can very clearly see. The one other sign which have been described is called napkin ring sign, where you have a low attenuation of the plaque in the center and a slightly high density around it, which people say this is due to a fibrous thin cap of the atheroma, or some people say it is the vascularization from the vasa vasorum. We do not know, but studies have shown if you see that feature on CTA, it is considered a high-risk plaque feature.
So the plaque morphology does matter. This low attenuation, positive remodeling, spotty calcification, and napkin ring, you seem to correlate with worst outcome and more obstructive coronary disease, more events. So I think this is really quite important. So, we have a lot of patients. These are patients that have gone a lot of times some previous intervention. Maybe they've had a stent. Maybe they've had, some coronary bypass. How do you, can you still see the coronary, the lumen or the inside of the coronary artery if you have a stent, or do you only like a certain size or?
Right. So stents, if they are large enough, 3 millimeter or larger, we can see them quite well. But again, depend upon the machine, what you have. If you have the dual source machine, which can really give you better spatial resolution, you can see within the stent itself. So in the size is one factor, what type of stent it is. Some stent produce more artifacts than others. Then we have certain technical features which can apply. Different sharp filters are there for stent evaluation when we're doing imaging. And we can give slightly higher MA to increase the radiation exposure to see the stent better. Also, we give higher rate of injection to see the stent better. So these are the factors which we can use to optimize a coronary CTA in patients with stent. Yes, we have seen many patients with stents where we could see in-stent stenosis. But these are usually larger stent proximal vessels, not smaller distal stents, which we really still cannot see it. There is other sign which is called a transient attenuation gradient. You can look at the contrast density beyond this stent. If the stent, the density of the contrast is still same or slightly decreased, it usually indicates that stent is patent, although you may not be able to see within the stent. But the caveat is, there can be a collateral circulation which can fill distally. So Stents, I think we can evaluate in comparison to calcium, which is still not evaluable. Now, bypass grafts are easy to evaluate because they are away from the heart. The cardiac motion does not affect usually that much. So these patients may not even need beta blocker. But we do need to cover more field of view. Most of the patients who have bypass graft, they usually have a lima and a saphenous vein graft. So for lima, you need to cover their origin from the subclavian artery and all the way down. But we do want to make sure the artifacts are less, the bleeding artifacts. And if you give beta blocker, they're useful. They will decrease the blooming artifact from the clips where they tie off intercostal arteries. We have seen saphenous venous graft very clearly. They are larger graft. They are easy to see. And we have seen good stenosis of these because of the plaques buildup.
So I'm kind of interested to see, it seems like, in the United States, we still go according to, kind of the guidelines. You have a patient coming with chest pain, it's still recommended to do the functional stress test, imaging, and if that is abnormal, then you can pursue with a CT angiogram. But in Europe, they go, particularly in England, they go with totally different philosophy, and the CT is really, becoming. When the patient presents to the emergency room, I mean, that's almost the first thing that is being ordered and performed. It looks like you're doing that also at UAB, Dr. Singh. Is that right?
And not 100%. It all depends who is on call in cardiology.
Right.
The younger people, they believe in CT, so we get more CTAs from them. But the older generation, unfortunately, they still believe what they have been taught, what they grow up. But yes, as you said correctly, the NICE, the England protocol now is CCTA first in patients with the suspected coronary artery disease. It actually started with coronary artery calcification in 2010, but in 2016, it turned over to CCTA as the first modality. I think here also it's probably going to change. The ischemia trial also showed that, the CTA has the same value as stress. So, and CTA can show you much more information, not just coronary artery. It can give you other information of other causes of chest pain. Patient may have a pneumonia, may have a PE or aortic dissection or severe esophagitis. We have seen all variety of cases which can mimic ACS.
Yeah, certainly, also in the Scott Heart, in England, well, not in England, in Scotland, they really saw the value of performing a CTA, really changing even the outcome of the patient, allowing maybe even better medical treatment in the patients where they were found to have, coronary artery disease. So hopefully this is probably the way, the field is evolving, with the advent of the coronary CTA at different centers, particularly with higher resolution, CT scans and better quality images and providing incredible information that it can be useful clinically, from the patient standpoint. It's a big advantage. Now, of course, we could look at a coronary artery and we could kind of see a narrowing or a stenosis. But how do we know, whether it's clinically significant? We deal with that in the cath lab all the time, where it's difficult sometimes. You take different views. You have a coronary stenosis that can be moderate to severe. So we've used, the wires and derive either an IFR or FFR or fractional flow reserve. I understand also this is a technology that is really progressing and evolving in the CT field. Are you doing that at UAB, Dr. Singh, the FFR, CT FFR?
No, we are not doing currently because of several reasons, mainly economic. Currently the third-party payers don't pay for it, and it is expensive. It's almost $1,100.
How is it done? I mean, is it just the software?
Right. So currently, most of the places, there's only one vendor, HeartFlow, which is doing the CT FFR. So the CT FFR is basically a computer based on computational flow dynamics algorithm, which is applied to coronary CTA images. And this CFD is commonly used in aerospace and automotive industries, and it is based on the pressure and velocities, physical laws of mass conservation, etc. So there is no special requirement for this. You just do a standard CTA, same protocol what we do. There is no additional imaging, no extra radiation exposure. You do not give any adenosine as compared to invasive FFR. Once the study is done, you send the study to heart flow people. And of course, they have their algorithm, use the supercomputational model based on CCTA, blood flow solution, and they will send you back the data, nice colorful images. The turnaround time now is around 4 hours or less. It used to be 24 hours, but even 4 hours is kind of high, if you're looking at acute coronary event. There is a second model, which is desktop model, which is provided by several vendors who make CT scanners, but they are not FDA approved. So you cannot use them. It's kind of a research source. But there are some people who are using it. It's basically machine learning, just like AI, it's expanding everywhere. It is already doing machine learning, and the data which comes out, people have compared with machine learning and CFD based, and this is very, very comparable. So I think that is the way to go. It is quicker, it is cheaper, and that information is there. And this information is very powerful information. As you said, looking at the stenosis means nothing. We know majority of the coronary events occur now in non-stenotic segments. So you have to know. Studies from invasive FFR have shown that, outcome from FFR-based strategies is much better than just catheter-based studies. Same thing applies to CTA as well. Patients who have done CTA and done second group CTA plus CT-FFR, the CT-FFR is way, way much better. There are many studies which were done during the evaluation of the CT-FFR. The last study was the NXT study, based on which the FDA gave them clearance. It showed the sensitivity specificity in the upper 80s, very good. So I think there are a few other trials also which have looked at the utility of CT-FFR, particularly the platform trial. It was, I think Pam Douglas at Duke, she is the one which was mainly involved in that. It was a prospective clinical trial, and that there are two groups, usual care versus CT-FFR guided strategy. And they found that obviously, most of the FFR guided, they changed the obstructive or categorization of patients. So many patients who were supposed to be obstructive with CT-FFR actually turn out not to have a significant hemodynamics. So the catheter angiography was significantly decreased by almost 80%. And also they looked at the 1 year data, and those patients who did not undergo catheterization based on CT-FFR, there was no adverse events for one year. And there was some other data that, the hospitalization or recurrent clinical visits were also less as compared to the usual care. So I think it is a very powerful tool, but it needs to be made available more readily and cheaper.
Right. Well, I feel like that's probably the way we're going. That's the way of the future, where you have a non-invasive, technique like a cardiac CTA, particularly combined with FFR, where you could really, streamline, the treatment of a particular patient, and bringing someone to the cath lab where you have increased certainty that may need, beneficial intervention. Otherwise, we treat medically, and you can really prevent, all this utilization of cardiac cath. Since we have so many that have, normal or non-significant disease in some labs, up to 40 or 50%, I can see the CT could have a significant impact in reducing, that number and have, be medically, more sounded, particularly from the cost basis.
It's accurate, yeah.
Well, Dr. Singh, really enjoyed discussing with you everything we wanted to know about the cardiac CT, from the calcium score to the cardiac CT angiography, from, prognosis to diagnosis, and then to prognosis again. So thank you, Dr. Singh. And this was a very valuable information for all of our patients. And we'll be able to kind of post that on MyHeart.net.
All right.
Thank you so much for the time.
Thank you very much. I appreciate the invitation, and I really enjoyed talking to you.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.